Good evening. My name is Tim Gibbs with Delaware Health Force. Welcome to the second in the series in partnership with Christiana Care. We're glad to have you here. Social media tags and the websites, DelawareMinimed.org and SussexCoalition.org. And Christy Handley, who would normally be here to introduce this evening's speakers, texted me to let me know that she will not be available this evening, so I'll take on that task. We're live streaming to YouTube, and Nicole, if you get a chance, if you could put that direct link in, or is that feature still not working for you?
I can do it.
Great, thank you very much. Just to recap about the program, the Academy was founded in 1930. Delaware Health Force is a partnership between the state of Delaware and the state's Academy of Medicine. This particular series is funded by ARPA money. That's the COVID Rescue Plan money. The partnerships that we have for today are Delaware Health Force with the Academy, Sussex County Health Coalition, and Christiana Care. You can attend as many of the sessions in the series as you would like. If you do attend all 6 live or 5 live plus 1, you would need to let us know that you missed one. You're going to do a makeup. Then you can get a signed certificate. Otherwise, you get a self-signed certificate that you would get online. There's no continuing education credit available for any of the adult learners in this evening's class, so no CE, no CME. And while there are no grades or tests, if you do miss a class, there will be a couple of questions that we'll ask just to make sure that when you went and reviewed the video, you got something good out of it. Program goals: we want to enhance health literacy in our communities. We want to expose the majority of you who are middle, junior, high school, undergrad students to a variety of topics from a variety of different types of practitioners. They're going to share career pathways with you. And importantly, this is an opportunity at the end to ask questions directly to the presenters. We'll go through those questions and pass on answers to the presenters, or we'll type answers directly into the chat. This is a Zoom webinar, not a Zoom meeting, so you don't see each other. You only see the presenters, and we, by the way, do not see you, the participants. We ask that you please use the Q&A feature to ask all of your questions. We don't use the raised hand feature. Just remember, don't ask any questions of a personal nature. We will do the best we can to de-identify or obscure if you do ask an interesting question, but we'll switch it around enough that we can ask it. We will do our best to answer all questions. However, what happens, especially now, is that frequently we do run out of time. And I understand that there are quite a few slides from our presenters for this evening, so we'll do the best we can to get to all of the questions. You do need to stay through the entire official presentation. After the presentation's done, we get into Q&A. At that point, you absolutely can leave. Q&A is when a lot of the cool stuff, however, gets talked about. Sussex County Health Coalition is our partner in downstate Delaware. We're located in Newcastle County, and Sussex County also covers Kent County. So they've been helping us get the word out about Mini Medical School. They care about virtually all the same things we do, including the growth of the healthcare and public health workforce. And so they're a great partner to have in this endeavor. Last week, we had Dr. Salam and Dr. Levine and a couple of other people, Tamika Chisholm and Liz Maston, talk about some just very general things about unlocking your career. This week, we have Dr. Julia Shamis, joined by Daniel Haas and Jide Okafor. And to introduce them, I am going to introduce Dr. Brian Levine. Dr. Levine is Associate Chief Academic Officer and Designated Institutional Official of Christiana Care. He oversees graduate and undergraduate medical education, as well as the VEST Center, that's the Virtual Education Simulation Training Center. He earned his medical degree from the University of Vermont, Larner College of Medicine, and is a graduate of the Emergency Medicine Residency Program at Christiana Care. He also serves as the Associate Medical Director for the LifeNet Aeromedical Transport Program. And at this point, I will turn it over to Dr. Levine. Brian, the floor is yours.
Wonderful. So this topic today is near and dear to my heart, obviously, because I trained in emergency medicine and I'm so excited for this. So I think you guys are all in for a real treat. So I do want to introduce the speakers. First, Dr. Julia Shamis, who's an emergency medicine physician and academic faculty member here at Christiana Care. She's from the Philadelphia area. She'll tell you a little about her journey, but she went to college at Temple, med school at Geisinger, so all very closely related to this region, and completed her emergency medicine training across the river at Cooper University Hospital. Next up, we have two residents who are so excited. That means they are in their training to become full-fledged practicing independent emergency physicians, which they're both very close to getting to. So first up, Daniel Haas, who is currently a third-year resident in emergency medicine. Emergency medicine is a 3-year training program here at Christiana Care. He did his undergraduate at Messiah, another local kid, and did Penn State for medical school, and his hometown is also pretty local in the capital of Harrisburg. And then Jide Okafor is another local kid. So it's sort of, we're all, and I'm from Long Island. So between all of us, we're within, 100 miles of each other. So Dr. Okafor is a second-year resident here at Christiana, completed his undergrad at Rutgers and went to Jefferson for medical school, which is technically Christiana's medical school, which is very cool. And his hometown is Hillsborough, New Jersey. So we're excited to have the three of you. This will be a lot of fun, and I'm sure we'll have some great questions at the end put in the chat and the Q&A, etc., and we'll get to it. So I will let Julie start it off, or Dr. Shamis, sorry.
Hi, I'm so glad all of you could join us today. We're going to start before we kind of get into our formal presentation. We're just going to give you guys a little bit of background on kind of each of us and how we got here today. Basically for me, just as Dr. Levine had mentioned, so I'm from the Philly suburbs. I grew up actually in Richboro, Pennsylvania. It's in Bucks County, if anyone's familiar or knows where that is. It's about like 45 minutes outside of Philadelphia. And from probably about middle school onward, I kind of knew I wanted to do medicine. I knew I wanted to be a doctor. I had no doctors in the family. I had no one for guidance, but I just decided this for myself and kind of somehow got here. And so kind of all throughout, I just started formulating interests, kind of getting involved in any way I could. So basically like finding people to shadow, getting exposed to different fields. And then in college, I kind of continued that. I went to college at Temple University in Philadelphia. I majored in neuroscience and I minored in bio. And I kind of set myself on the path of pre-med. And then I actually ended up taking a gap year. I did apply initially when I graduated college and I didn't get in at first. It happens. And what I did in my gap year is I went to work. And so I actually worked at a private practice for respiratory and sleep medicine for a year. I worked as a medical assistant. And then I also got to take 5 vacations that year. So it's really not all bad to take a gap year. And then once I applied the second time, I actually got a lot of acceptances. So I think oftentimes nowadays schools tend to like seeing people take gap years because they like you to have a little bit more life experience, work experience, and kind of get exposed to more in that year and time you have off. I ended up going to medical school at Geisinger Commonwealth School of Medicine in Scranton, Pennsylvania. It was a great experience. I went into medical school thinking I was going to be a neurologist. Little did I know how much I would not like neurology once I got exposed to it. And really, the key to kind of going into medicine, I think, is having an open mind. I really knew very little about emergency medicine and hadn't had much exposure. But then, kind of going into my first and ultimately second year of medical school, where we got a lot more education on what emergency medicine is like, I realized that it was everything that I wanted to do. And so then I applied for residencies and I got my first choice, which was Cooper. I wanted to be there just because of proximity to home. It's right in Camden, New Jersey, and I thought it would be a great training experience. I did also interview at Christiana, and I did really like Christiana, but unfortunately, it was a little bit further away from family, so I wanted to stay closer to home while I was in residency. And then I graduated from residency last year, so I finished in June of 2024. And so then I was looking for jobs throughout the third year of my residency, and Christiana really stood out. I already liked everything from when I had interviewed there for residency, but I kind of liked everything they had to offer. And I ended up becoming an academic faculty member shortly after I got hired, and it's been great so far. And so that's kind of where I got to where I am today.
I guess I'll go next. Hey everyone, good to be here. My name's Dan. Same thing from the slide. I grew up in Central PA. I went to like a small private school for high school, went to a small private school for college. Long story short, I knew I wanted to go into medicine kind of pretty young, but didn't really decide on it until college for a couple different reasons. I grew up with some family friends, one of which was an emergency medicine doctor. Interestingly, I did martial arts from a really young age, and the guy who taught me was a combat medic in Iraq who taught me a lot of stuff about some medic-y things that I found really interesting. So I was actually thinking about doing like EMS and things like that, and then I ended up going to college and realizing I really liked biology and chemistry and liked more of the hard sciences behind it. So I ended up going to medical school. Didn't have to take a gap year. Went straight into medical school from into Penn State right after college, and knew I wanted to do emergency medicine pretty quickly into my third year when you start doing rotations for a lot of different reasons. But for you guys specifically, it's just honestly really cool. You get to see a lot of different things. You get to help people out a lot of the time and actually have some uh, I don't know, job satisfaction for me, where you're getting to do some procedures and getting to so hopefully, every now and then save some people's lives, which is kind of why I wanted to go into medicine in the first place. Came down here to Christiana for training, which was my first choice because one, it was close to family, but also two, because it's just a great training environment. We see a lot here. We see really sick people and we get to do a lot. And there aren't a lot of other trainees that are going to take things from us, which is something that you can think about later in your training. So, yeah, happy to be here. Hopefully, we can give you guys some good tidbits and some stuff to think about going forward.
Hey everyone, I'm Jide, one of the second year EM residents that you guys already heard. So I'm from New Jersey. I was actually born in New Brunswick, where I had part of my childhood, and then moved up to Hillsborough, where I did high school. A big reason why I went into medicine, I already was interested in science as a kid, and I really liked it. But my older brother actually had pretty bad scoliosis, and he had to have surgery to have a metal rod put in his back. And that was kind of the first big slash major surgery in the family. And kind of going through that experience and the care that we had gotten from all the doctors and nurses made me really want to provide that same care to others, and was a big proponent to me wanting to go into medicine. So while I was in high school, I ended up volunteering at local hospitals. And then in college, I also majored in neuroscience, and was a scribe in the emergency department, um, which started my exposure to emergency medicine. Um, and so ultimately went to college at Rutgers, or excuse me, graduated Rutgers, went to med school at Jefferson, where, got to do the different rotations. Of course, because I majored in neuroscience, I was also interested in neurology. But just the diversity and seeing all the undifferentiated patients in emergency medicine made me really interested in it, and want to pursue it. And, now I'm a resident at Christiana, which is also close to family because New Jersey is not that far, and neither is Philly. It's just been a great experience seeing all the different people and patients that come into the emergency room and that I get to work with. So I'm really excited to share some of that with you guys. And so I'm going to get into our presentation here. All right, so this is going to be our mini med school session for emergency medicine. I'm going to be basically introducing you guys to emergency medicine, some of the things that we see and do, and then Dan will take over to talk to you guys about some cases. So let's get into it. So emergency medicine, doctors in emergency medicine are essentially specialists of acute care and resuscitation, which means that we have to be ready for anything to walk in at any time. That can be as simple as someone who just stubbed their toe and give them some Tylenol, or someone that's having a heart attack. And we need to know how to recognize that and to act on it. So rapid decision making is very important. And we also treat everyone that walks into the emergency room, regardless of their background or their ability to pay, which is also a very appealing aspect of emergency medicine to me. So I wanted to briefly talk to you about some history of emergency medicine, because back in the day, there was no emergency medicine, or rather there was, it just wasn't called that. People needed acute care that the system couldn't accommodate. And so specialization of emergency medicine kind of started to gain traction in the 60s. So in 1968, this group called American College of Emergency Physicians was formed, which was kind of the driving force for having EM be recognized as a specialty, and is still the largest kind of representative group today. In 1970, the first residency program for EM was developed, and that was at the University of Cincinnati. And in 1976, these two groups were formed. That's the American Board of Emergency Medicine, which basically develops the board exam to officially say that you're now board certified or able to say that you're fully specialized in emergency medicine. And then the Society for Academic Emergency Medicine, which helps to develop the curriculum for what emergency medicine doctors should learn and know. In 1979, emergency medicine was officially recognized as a specialty by this other board of American medical specialties, which is made up of things like OB, ophthalmology, that voted to agree that emergency medicine should be its own specialty. And that same year, Christiana actually established its own EM residency. So 1980 was the first EM board certifying exam. In 1986, this law was passed called the Emergency Medical Treatment and Active Labor Act, which basically was meant to ensure non-discriminatory access to emergency care, which, like I said, we treat everyone regardless of their background or ability to pay. In 1991, the first combined EM residency program was established with internal medicine. And this is also the same year that Christiana developed its own EM-IM combined residency. And in 2007, the first combined EM program with family medicine was established, and that was actually at Christiana, so we were the first ones. So EM is now practiced in many countries worldwide and continues to expand. So we're already talking about the emergency department, but what about urgent care? So urgent care is where you'll go for non-life-threatening issues. So things like a simple cut, maybe a minor asthma flare-up. You'll go to urgent care and they can handle those things. The emergency room is generally more so for life-threatening emergencies, big or deep cuts, heart attacks like we already know, severe traumatic injuries. And there's different types of emergency departments that can handle basically different things. So with trauma centers in Delaware, there's levels 1 through 3, which essentially just means how much access they have to certain specialties in medicine to manage more severe traumatic injuries. And then there's other things that we consider like STEMI or stroke-capable hospitals. That is to say, if they can handle, if they have a cath lab to manage people having heart attacks or to manage people having strokes. So Christiana, for example, at Newark is a level 1 trauma center because it has access to a lot of specialties like neurosurgery and is capable of handling strokes and heart attacks. So the path to emergency medicine, we kind of talked about this briefly, but you'll finish high school and then go to undergraduate college. You'll go through medical school, which is usually 4 years, and then you'll go to residency, which is also usually 3 to 4 years. Christiana is a 3-year program, but there's other programs in the country that are 4 years. And if you're interested in a combined program like EM-IM or EM-FM, you could do a 5-year program, and then you could take your certifying board exam after that. So now I'm going to talk about some of our responsibilities and what we do in the emergency room. So this is an overview of kind of our workflow. So a patient will come in, they'll undergo an initial assessment, stabilization if they need it. We'll try to establish a diagnosis, treat them, and then determine their disposition, if they're staying, being admitted to the hospital, or going home. So the initial assessment basically looks like something that we call triage, which is essentially asking, does this person need to be seen right this moment, or can they wait? So we look at things like their vital signs, how fast is their heart beating, how fast are they breathing, what's their oxygen level or oxygen saturation, what's their blood pressure, and what's their temperature? Do they have a fever? How does the patient actually look? Do they look really sick? Are they huffing and puffing? Are they grabbing their chest? Or are they kind of just, walking around comfortably and able to talk to you? And then the next question we ask is, does an alert need to be activated? So we get an EKG, kind of like a snapshot of the heart to see if they're having a heart attack. We do a neuro test to test if their brain is working well, to see if they're having a stroke. And then we look at their injuries to see if we need to do something called a trauma alert. So stabilization, we basically use our ABCs, which stands for airway, breathing, and circulation. So these are asking 3 relatively simple questions, which is A, is the airway clear? That is to say, is there literally anything in the mouth that is preventing them from being able to breathe? B, is the patient breathing? Can I hear their lungs on both sides when I listen with the stethoscope? Are they huffing and puffing? And C, is the blood pressure low? Can I feel a pulse? And do we need to give them something to help with their blood pressure? So we intervene as needed in each of these things. When it comes to diagnosis, we basically take a constellation or a combination of all of these different aspects of our evaluation in the emergency department. That'll be their vital signs, our physical exam when we listen to your heart and lungs, press on the belly. Like I said, do the kind of brain test to make sure that the brain is working well. We'll check blood work. We'll do imaging studies like X-rays, ultrasounds, and CAT scans. And for ultrasound in particular, we do something called point of care ultrasound, or POCUS, which is us using it in the emergency room. And all of that together helps us come to a diagnosis for whatever is going on with the patient. So just to talk about POCUS a little bit more, you may have already heard of ultrasound because that's what pregnant women will have done to take a look at the baby, which we also do in the emergency room. But we also use it to take a look at the heart, and we use it to take a look at the gallbladder and see if there's gallstones. And in trauma settings, we also do something called EFAST to look for signs of severe traumatic injury, which I'll briefly talk about later. When it comes to treatment, we do things for stabilization. So if the oxygen level is low, we put them on oxygen. If the blood pressure is low, we might start IV fluids. If they're having a fever, we'll give Tylenol. Pain, we'll give pain medication. If they have an infection, we give antibiotics, etc. And then in some cases, we might have to do a procedure. So what procedures do we do in the emergency department? Frankly, it's too many to list, but these are the big ones that I wanted to talk about. So laceration repairs, you come into the emergency room or urgent care, you have a cut. We'll take a look at it. We'll wash it out to make sure that there's nothing inside it or that there's no obvious signs of infection, and then we'll close it up. There's different options that we have to do that. You'll maybe already be familiar with like sutures. Other things that we do would be staples. Oftentimes, if there's a wound on the top of the head, we might do that. We also use something called steri-strips or skin glue if it's a lower tension wound or we just need to kind of bring 2 small pieces together, like the skin just got ripped off and you just need to flap it over. And with these procedures, there's also some risks that we think about. So some risks with doing these laceration repairs would be an infection, but we of course clean it up first before we close it. And then a cosmetic issue, because if you have a cut and then we close it, you could get a scar and that might not be pretty. With incision and drainage, this is basically you come in with an abscess or essentially a bump that is filled with infected fluid, essentially. And so what we'll do is we'll put some numbing medication around the area and we'll cut it open and drain it out. The risk for this is that if we don't get it all out, there's a risk of it kind of building back up, and then damage to surrounding stuff if, we cut too deep or go a little too far towards like a blood vessel. But this is something that we can avoid, especially with ultrasound, to be able to see exactly how big the abscess is. Another thing that we do is foreign body removal. This can essentially be anywhere. Big places would be in the nose, in the ears, maybe even in the mouth or on the eye. And it could really be anything from like toys to food to rocks. And we use a variety of tools to remove these things, whether it's really small like forceps to grab things from the nose or the ears, or even like little sort of tools that we can use to suction them out. And the risk here would also be damage to surrounding structures, in your nose, your ears, some bleeding from the kind of trauma of dragging these things in or out, and then also infection, especially if something is in one of these places for too long. Fracture and dislocation reductions. This is kind of a mouthful, but basically it's saying that if you come in with a broken bone, then we determine if it's dislocated or not. If it's dislocated, it might need to be reduced, or in other words, relocated back to its regular position, and then we would splint it or put a cast over it to try to keep it in place. If it's broken but not dislocated, it might just need a splint or cast or sling, again, to just keep it in place. If the joint is just dislocated, then we would reduce it, or again, in other words, relocate it back to its regular position. The risk here would be damage to a nerve or blood vessel that's nearby, depending on where the fracture or dislocation is. Pain. So oftentimes we'll give pain medication or even put the patient to sleep before we do this so they don't feel the pain. And then need for surgery if we're not able to successfully reduce this in the emergency department. So I wanted to go over a couple of examples of what I mean when I say that something is broken or dislocated. And so that's what we'll do now. So on the left here, you can see the wrist from a side profile. And on the right, you kind of see it head on. And so we like to get x-rays in two views in the emergency department and really just in general, because it helps us know not only if something is broken, because we can see it from multiple angles, but also if it's dislocated in one direction or another. So this is an abnormal wrist x-ray. So you can see, compared to this, that something is off here. So when you look over here, it might be a little bit more subtle, but you can tell that this lip right over here really shouldn't be there. So you can tell that this is broken, but it's hard to tell here if it's really that dislocated. So when you look at the other view, you can tell that it is pretty badly dislocated. And this is an example of something that we may try to reduce in the emergency room, but also would need to see an orthopedic surgeon. And here's a couple examples of shoulder x-rays. So on the left here, you can see this is a normal shoulder. It's sitting, in this kind of joint space that it should be. And on the right, you see that it's all the way down here. So this is a dislocation of the shoulder, and this is also something that we would reduce or relocate in the emergency department. And we would put this person in a sling so that they don't go throwing their shoulder around again. Another procedure that we do is intubation. That is to say, putting in a breathing tube. And we'll usually do this if the patient is having persistently low oxygen levels, even after we've tried to put oxygen through their nose, through their mouth, and we still can't get those levels back up. Another situation that's more nuanced for when we would intubate someone is if they can't reliably protect their airway. What that means is if someone is very confused and they're vomiting, there's a risk that they might not cough up the vomit if it were to go down the wrong pipe. And so that's a risk of choking. To prevent that in those very confused patients, we may intubate them. But that's a more nuanced situation that we might intubate somebody. The risks here would be that when you're putting the breathing tube in, it's possible to put it basically into the wrong pipe. And so instead of going into the breathing tube, it goes down to the feeding tube and goes into the esophagus. The other risk would be if the patient had too complicated of an airway for us to intubate, they might need to go to the operating room or have surgery, put the airway in by cutting instead of just putting the tube in through the mouth. Another procedure that we do is called a chest tube, which is exactly what it sounds like. So we put a cut into the chest on the side and put a tube in. And there's really two big situations that we do this. One is when there's a collapsed lung that we call a pneumothorax. And two is when there's fluid around the lung, and that's called a pleural effusion. And the risk here, of course, is because we're cutting, there's a risk to damaging surrounding structures, risk of bleeding, and then a risk of infection with us putting, now a foreign object, a tube, into the chest. So I wanted to show you an example of a normal chest X-ray. So these are the lungs on the sides here. And all this white stuff is basically the blood vessels that are going out to your lungs. Okay, so this is normal. The darker parts, the more black parts, that's air. So I wanted to emphasize that it's normal to see these white parts because when we look at this, you can see on this image, this lung has those kind of white lines going out like I told you about that are normal. But on this side, you see a lot of black. And then you see some of those white lines down here. So this is all air, and this is the lung that's collapsed. So this is an example of a pneumothorax. And this is an example of one that's certainly big enough for us to want to put a chest tube in. On this image, again, you see these white lines going out that I told you, you want to see that's normal. But then over here, you see a lot of white. You see a lot of white and it curves up over here. This tells us this is most likely fluid that's surrounding the lung, and this person is probably having a hard time breathing. So we would want to put a chest tube in here to drain out this fluid and help the lung re-expand. And so this is an example of a chest tube that's in place. Actually, this one is a little too far out. This should be a little deeper in, but it still gets the point across that you see again, this side is normal. And this side has all this black space here, and then you have the chest tube, and this will help drain out the air and give the lung a chance to re-expand. So the next part of what we do is disposition. So it's basically determining, is the patient staying or going? Do we discharge them to go home, or are we admitting them? And depending on how sick they are, will tell us, do they need to go to the floor, or are they very sick and they need to go to the ICU? So just to go over everything that we just talked about, because it was a lot, the initial assessment is a brief evaluation. We do vitals, we do a brief assessment to see how sick someone is, kind of as a snapshot. Next is stabilization as needed, diagnosis using different tests and imaging, treatment using different medications and procedures, and then disposition, which is determining if they can stay or go. So I'm going to talk to you about some common emergencies, starting with some common presentations in the emergency room in the first place. So someone might come in and say they have chest pain. And so you have to figure out, well, is the chest pain just because, they're just going too hard in the gym and benching too much? Or are they having a heart attack? With abdominal pain, you have to wonder, okay, are they having a stomach bug? Or is there a surgical concern? Is there something going on in their belly that they might need surgery for? With respiratory distress, we have to ask ourselves, is this just another asthma flare-up? Just need some albuterol and some steroids? Or do they have a collapsed lung, like we talked about before, and do they need a chest tube? And then trauma, that itself is a huge range of someone just stubbing their toe or having a broken bone. So I'm just going to talk about really the far side of the emergency department, which is the big emergencies. And I'm going to talk about a few emergency alerts that we have at Christiana. So the stroke alert, STEMI alert, which basically means heart attacks, and then trauma alert. So for a stroke alert, we use something called the National Institute of Health Stroke Scale, or the NIHSS, which basically is a way for us to score how bad someone's symptoms are in terms of whether or not they're having a stroke. So the things that we look for are they really weak on one side? Are they ignoring one half of their body? Are they not able to speak like they normally would? Are they off balance? And another big thing that we look for is the time from the last known normal. So when the last time that person was completely normal before their symptoms started, because that determines what we can do to intervene. If it's been 4.5 hours or less than 4.5 hours, we can give a medication that's called a thrombolytic, or in other words, a clot buster. Because oftentimes a stroke is being caused by a blockage in a blood vessel in the brain, and giving a medication like this, a clot buster, can help improve symptoms. If it's been 24 or less than 24 hours, then they can still get something called thrombectomy or mechanical intervention, where they can go and essentially try to clear the blockage mechanically. So when it comes to recognizing a stroke, kind of put it into more simple terms that you may have already heard of, there's this mnemonic called be fast. So the B stands for balance, like a loss of coordination, can't walk straight. E stands for eyes, so vision changes, being unable to see in certain areas. F stands for face, so that's drooping on one side or not being able to move one side of the face. Arms, well, A stands for arms, but really it's for arms and legs, which is weakness or inability to move the arm and or the leg on one side. The S stands for speech, so that's slurred speech, having a hard time getting words out, or having a hard time understanding what others are saying. And the T stands for time, because we like to say time is brain. And so if these symptoms are being recognized by a layperson out in the community, then it's important for them to call 911 and for this person who's experiencing these symptoms to be seen in the hospital. And generally speaking, when it comes to determining where a stroke is happening in the brain, the right side of the brain controls the left side of the body, and the left side of the brain controls the right side of the body. And so if someone comes in and they're not able to move their left side at all, then that hints to us that they're probably having a stroke on the right side of their brain. Next, I'm going to talk about STEMI alerts. So like I said before, this is for people that are having heart attacks. So STEMI stands for ST elevation myocardial infarction, which sounds very complicated. And so I'm just telling you it's called a heart attack. And so this is for someone that's coming in classically with sudden crushing chest pain, feels like an elephant is stepping on their chest. And so for these patients that come into the emergency room, even if they're not having this crushing chest pain, if they're saying they have chest pain, we're still going to do an EKG or ECG within 10 minutes. Just a quick sidebar, you might see ECG and EKG. These are the same thing. It's just that the original form of the word was an electrocardiogram uses Ks, which is German, and so that's EKG, and then in English it's like it's cardiogram C, and so it's ECG. So when we do these evaluations of the EKG, we can tell if the person is probably having a heart attack or not, and then that lets us call the STEMI alert as early as possible. And so a couple of medications that we'll give to help with their symptoms and to help improve their outcome would be aspirin and nitroglycerin. And the treatment ultimately is to talk to a cardiologist and for them to get to the cath lab to have mechanical clearance of the blockage in the blood vessel of the heart so that their symptoms can be improved and they can recover. And so this is another one where timing matters, and we want the door to balloon time to be within 90 minutes. So just briefly, I wanted to talk about EKGs and show you an example of what a normal one might look like. So this is really the area that we care about here. This part right here, we call the S, and this part over here, this hump, we call the T. And really what we care about is for this part here to start and end at a similar place. So this one starts and ends at a similar place. So this is not elevated. This one starts and ends at a similar place. So it's not elevated. Okay? Then we look at this. And this is an example of a STEMI or ST elevation because this S part and then this T part, the part in between them is higher than it should be. So this is where it starts and this is where it ends. So it's higher than it should be. And that's why we call it an ST elevation. It's the same thing over here, but not over here. So depending on where it is, hints to us where in the heart that blockage might be. But ultimately what we care about is if we see this kind of elevation, we're thinking that they're having a heart attack. Next is a trauma alert. So this is basically when we see a patient that just had a trauma, such as a car accident, if they got into a fight, and they have significant injuries that are life-threatening, basically, and need to be immediately evaluated and maybe even intervened on. That would be things like bleeding, head injury causing significant confusion or coma, or injury to critical areas of the body that's like your chest, your belly, or your back. So we follow something called Advanced Trauma Life Support, or ATLS. And so we do something called a primary survey. That's the ABCs that I told you about before. The secondary survey, which is a full head-to-toe physical exam, and then imaging studies. And again, we determine their disposition for where they go after we evaluate them. So to go over ATLS some more, the primary survey is the ABCs, and you can see I snuck in a couple other letters there. So there's D and E as well. So ABC is airway, breathing, and circulation again. And again, we intervene on each one if needed before we move on to the next. D and E stand for disability, which basically is trying to say, are they in a coma or are they awake and able to talk to you normally? And E stands for exposure, which is basically just taking off all their clothes so that you can see every part of their body that might have been injured and to make sure you don't miss any injuries. So the secondary exam, will take place after they're fully exposed, and you'll look at every part of their body to make sure that there's no traumatic injury that you're missing. And then we'll do imaging studies, which would be things like X-rays, ultrasound, which is the EFAST that I briefly mentioned before, and CAT scans. So EFAST stands for Extended Focused Assessment with Sonography for Trauma. It's basically just using ultrasound, specifically in a trauma setting, to look for concerning findings. So there's 5 views that we do for this. Subxiphoid, which is basically under that bone in the middle of your chest, is the part right underneath it that we use to look up towards the heart to look for signs of fluid around the heart. We do right upper quadrant, which is basically the right side of your belly. We go on the side there to look at the liver and the kidney, and we look for fluid there. If there's signs of fluid there, that makes us worried that there's bleeding in the belly. We do the left upper quadrant for the same thing. We look at the spleen and the kidney on the left side. We do a pelvic view that's much lower to take a look at the bladder and see if there's bleeding around there. And then we do lung views. So we look at both lungs to see if there's signs of a collapsed lung. And so next is the disposition of these patients who have traumatic injuries. So if it's, let's say, someone that was in a car crash, but they maybe have a little bit of pain in their belly, but they're not having any concerning vital signs. Their heart rate isn't very fast. Their oxygen levels are good. If their EFAST is positive, that is to say, if there's signs of fluid or bleeding somewhere on the exam, they'll get a CAT scan and we'll see where they need to go from there. If the EFAST is negative, they may still go to CAT scan. Most of the time they really will, at least at Christiana. Or other things that might be done would be to do serial EFAST exams, that is to do another one later and to see if it changed, or they'll just be observed until it's safe for them to leave. In an unstable patient, someone who's sicker, if the EFAST is positive, that might just be a sign that they should just go straight to the operating room. Don't stop at the CAT scan, just go straight up to the operating room. And if the EFAST is negative, they may go to CAT scan, but oftentimes they'll be stabilized first to be able to tolerate going through the CAT scan. Of course, there's variation on a case-by-case basis, and this is all dependent on each patient. But that's basically the big things that I wanted to talk to you about. So that's kind of my introduction to emergency medicine at this point. I'm going to hand it over to Dan to go over some cases with you guys.
All right, guys, give me a minute to share my screen here. We're going to go from the exact same place. All right, so these are just a couple cases that I made up, which are super low key. They do not affect your grade. I didn't even realize you guys were going to get a certificate for this. This has no effect on that. This is something, if you would like to join, please feel free. It'll be more fun if more people join. You can log on to this website or text this thing. It's a couple multiple choice questions we're going to go through. I have 9 cases. There's almost certainly no way we're going to get through all of those. So whoever's running this, please just interrupt me at some point and let me know that we're done, and then we'll move on to the Q&A. So I'm going to move on to the first case here, and then I have to activate the thing. So the first case, actually, let me give you guys a minute to log on if you want. All right. So the first case is a 73-year-old male presenting with drooping of the face and an inability to move or feel the left side of his body starting about an hour prior to getting here. So basically he can't do anything with his left side. And I'm gonna have to activate this.
Does anyone else have access to the slides he's using? Because maybe they can copy and paste it in the chat. So
Yeah.
other attendants who are late to log on.
There we
Yeah.
go.
Some people are asking about the site.
I can paste it in.
Okay, thank you so much.
Yeah, Jide, you actually might have to share your screen here because I'm not entirely sure I can look at this and share my screen at the same time. Can you just share your screen and I'll tell you when to move the slides?
Yes. I'm just gonna send this and I will share my screen again. Give me a moment. All right.
Looks good.
Looks good?
Yep, we see it.
All right. So, like I said, this is a guy who basically is coming in and can't feel the left side of his body. So my question for you guys is, what is the diagnosis? It's either A, B, C, or D. Oh, we got some people coming in. We got some stuff coming in. Right. Nice, nice, nice. All right. All right. Jide, you can go ahead and hit the next button. So,
Oh, sorry, Daniel. People in the Q&A said there are no answer choices, just A, B, C, D.
oh yeah, you have to share the screen. That's dumb.
Okay.
Jide, where'd you go? Oh, we lost Jide. That's why. Okay, so here's what we're gonna do then. I'm gonna share my screen again. Jide's computer crashed, so here's what we're gonna do.
There we go. Yeah, that works.
All right. So I might not be able to do this like I wanted to, but that's okay. So the diagnosis here is just a lot of you were getting it as stroke. Right, so this guy can't move, he can't feel the left side of his body, just like we talked about. That's pretty classic for a stroke, and that's something that you guys actually might see out in the real world. And the big thing for recognizing this is just recognizing it as fast as possible and getting them to a place where we can help them. They're gonna either get a drug like a clot busting drug to help with that, or they're gonna go somewhere where and somebody who's like an interventional neurologist can actually go in and look and see where there's actually that blockage in their brain and go in and remove it. So that's one of the cool things that we can do here. The next question for this one, which I was going to ask just to see if you were paying attention to today, was what side of the brain is most likely affected here? So basically, right, this person has left-sided deficits. They like can't feel the left side of their body. So the question is asking, is it the right side of their brain or left side of their brain? So which side controls the left side of the body? And if you were paying attention to Jide, then you would know it's actually the right side. It's interesting. The right side of your brain controls the left side of your body, and the left side of your brain controls the right side of your body. So interestingly, all of us who are right hand dominant, like I am, actually are left brain dominant. And this has some implications for when we see people to determine exactly what part of their brain is most likely affected. All right. This is the second case that we were going to do. This is a 42-year-old guy who basically fell off a ladder and he hurt a snap in his leg. And you see it, you look at his leg and you see his leg is busted up. You see bone coming out and it's obviously deformed. And this is his x-ray. And you see here that these bones don't look like they're supposed to look. In fact, they're all shattered around here. So something's going on here. And the question here was going to be what bone is broken. Is it the humerus? Is it the tibia? Is it the ribs? Is it the clavicle? And for those of you who know bones, right, the answer is going to be the tibia. That's going to be the big bone down here in the lower part of your leg. The smaller one is the fibula, which is an answer choice here. Your humerus is up here, the top part of your arm. Your ribs are your ribs, and your clavicle is up here. It's one of the more common bones that gets broken, especially for anybody here who likes to do snowboarding or skiing. So, like Jide was saying, this is like a very, malformed fracture that's not where it's supposed to be. So we probably need to do something about this. But this is actually not just a normal fracture because you can actually see the bone. It's something called an open fracture. And an open fracture, if you all have heard of this, is a fracture that's exposed to the outside environment. So that basically means a fracture that's broken through the skin. So you can actually see the bone. And we get concerned about those, not because we really do anything different for the fracture, but we get concerned about them because, your skin's there for a reason. It's there to keep the stuff that's supposed to be outside of you and keep the stuff that's supposed to be inside of you. And some of the stuff that's supposed to be outside is bacteria and things that can cause infection. And so when you have open fractures like this, you're much more likely to get an infection. And so we tend to deal with these a little bit more seriously. Third case, another one you guys might be familiar with from today's lecture, is a 55-year-old who's coming in with terrible chest pain. It's been going on for about an hour. He's got this pain that goes from his chest up into his neck, into his arm. He's all sweaty when you see him. He's vomiting. He just doesn't look great. And if you remember today's little lecture here, you see these little elevations here, we call them, right? Like this isn't where it's supposed to be on the EKG. And so we know that this is a heart attack. And just like actually like a stroke, right? A stroke is basically a blockage in the brain. A heart attack is a blockage in the heart. And so just like we do for a stroke is we gotta fix this somehow, either by giving a clot busting drug or by getting them to a place where somebody can actually go in and take out that blockage. And the faster we do that, the better the person is going to turn out. One of the other things we do for these people is give them some medicine. We give them a lot of different medicines, but only one of them actually has been shown to reduce mortality risk. And what I mean by that is only one of them has been shown to actually reduce people dying, which is what we care about. And that's aspirin. So anybody who has any sort of chance of having a heart attack, they get aspirin. Aspirin is a great drug. You probably have it at home. We use it for pain. We use it for all kinds of things. One of the things that we also use it for is for heart attacks. Fourth case. So this is a 15-year-old female. She's coming with some fever, some nausea, some vomiting, some belly pain. This has been going on for about a day. But interestingly, the pain started kind of in the middle of her belly, and now it's going to the right lower part of her belly. And I don't know if this is something that you guys would know, but what's the diagnosis here? I give a bunch of options here, and the answer is actually going to be appendicitis. And the reason I bring up appendicitis for you guys is because it's the most common surgery that somebody in their teenage years will have. And appendicitis is basically just an infection of the appendix, which is a part of your intestines, a part that we don't really need. And so the way we fix this is by giving antibiotics to fight the infection and also by removing the appendix so it doesn't happen again. And there's a bunch of different organs that you can end up removing, including the appendix, that, don't necessarily affect the way you live. And so that was going to be my next question, which is basically there are 3 of these organs that you can live without and one of them that you cannot. And the one that you can't live without is the liver. Well, you don't remove the liver. Now, sometimes you can remove part of the liver and give it to somebody else with a liver transplant, which is like super complex and complicated, but also really cool because your liver will actually grow back if it's injured. But the rest of these you don't necessarily need. You can remove your spleen, you can remove your gallbladder, you can remove your appendix, and we do this a lot for a lot of different reasons, including infections and other things. Fifth case. This is a 27-year-old. He got shot in the chest. Not good. He doesn't look great. He's not breathing well. His oxygen is really low. He's got a really low blood pressure. We get an x-ray going through our trauma protocols. And I don't know if you remember what Jide was saying, see how these nice white lines on this side, they're supposed to be there, but you don't see them on this side. And so this guy has a collapsed lung, probably from getting shot in the chest. But he doesn't just have a collapsed lung, he also has low blood pressure, he's not breathing well. And so we got to do something to fix the problem. And the way that we're going to fix this problem is by reinflating the lung. And the way that we're going to reinflate the lung, if you remember, is by putting a chest tube in the lung, which is actually a pretty simple procedure, one that we do relatively often, and that's pretty well tolerated. And we just basically re-expand that lung, and hopefully things get better. This is a case that's taken from reality that some of you might be aware of. This is a 26-year-old football player who collapsed on the field after being struck in the chest during a play. He had no pulse. He had a check done. They checked the electricity in his heart, and it showed an irregular pattern called ventricular fibrillation, or VFib, if you've heard of that. And he started to get chest compressions. So this is a question that a lot of you probably know the answer to, which is, which song are you supposed to do chest compressions to? And for all of you Office fans out there, you'll know that the answer is Staying Alive, which is the song that most people will know. But actually, you can also, ironically, do it to Another One Bites the Dust. Has the exact same beat and has the exact same tempo. The next question is, so this was taken from a football player recently, Damar Hamlin, who played for the Bills, who actually got hit in the chest during an NFL game a couple of years ago and collapsed on the field and had medical resuscitation done and went into the hospital and completely recovered and now is playing again, which is absolutely crazy and a really cool story. But this condition, I wonder if any of you know what the answer to this is, whether it's second impact syndrome, commotion cordis concussion. And the answer is commotio cordis, which is basically a very, very rare condition that can be caused by getting hit in the chest during a very, very specific part of the heart cycle. Very, very uncommon because you have to hit it almost perfectly dead on during a very specific time, but it has been known to happen, and that was an example of it. All right, case number 7. This is an 18-year-old college student who has been having a worsening headache and some fever over the past couple days. She's also coming in saying she really can't move her neck all that well. It's really stiff. And she has a lumbar puncture performed, which Jide actually didn't talk about. The colloquial term for lumbar puncture is a spinal tap. It's where we actually go into the back and take a small sample of fluid, cerebrospinal fluid, which is basically the fluid that your brain lives in, and it gets tested, and we see that there's a bunch of bacteria floating in that fluid, which is not a good thing. It's not supposed to be there. So this type of thing is basically a brain infection. It's called meningitis. And we see this a lot less often now than we used to because of vaccinations and things like that, but we still see it every now and then. And it, in theory, is somewhat more common in congregational living facilities like college. But this is something that we take really seriously, obviously, because you need your brain for a lot of different things. And if you get an infection there that we don't take care of, then things can go badly pretty quickly. So this person gets started on medicines very quickly, specifically antibiotics, right? We got to fight that infection, and they get watched very closely, and they probably need a couple other things to make sure that they get better and not worse. So this is case number 8. So this is a 23-year-old male. He has type 1 diabetes, so he has a specific type of diabetes that means he can't make insulin on his own. And he's coming in with nausea, vomiting, and really bad belly pain that's been worsening over the past couple days. And this started after he ran out of his home medicines about a week ago. His blood sugar, when you see him, is really, really high, and his blood is really, really acidic. And neither of those things should be the case. So this is something that we actually see a decent amount of time, and some of you may be familiar with, and some of you may not be familiar with. It's something called DKA, diabetic ketoacidosis, which is basically a really fancy term for saying that when you don't have enough insulin in your body, that your body starts to starve. So even if you eat a bunch of things, insulin allows you to absorb the nutrients that you're eating. And when you can't do that, your body thinks that it's starving and starts to make these acidic compounds to try to compensate for that. And that allows you to go on living, but it also makes your blood really, really acidic, which can cause a lot of different problems, including having really bad belly pain and nausea and vomiting. And so the way that we fix this is by giving insulin because they can't make insulin, and so we give it back to them. Not super complicated, but these patients get very sick very quickly. Some of them do need to get a lot of resuscitation, and others turn around very quickly. But it's something that we see a decent amount in the emergency department. All right, this is the last case, and one that probably a decent amount of you are familiar with, unfortunately. This is a 17-year-old male. He's presenting with a sore throat. He's got palpable lymph nodes, which basically means that he has these like little pinpoint things on his neck that you can feel that are kind of hard. He also has these exudates on his tonsil, and by exudates, I mean all this white stuff that's not supposed to be there. You get a swab, which means you go back and you get a little sample of that stuff, and it grows positive for group A beta hemolytic bacteria, which is a fancy word for saying just a specific type of bacteria. So, what's the diagnosis? This is good old-fashioned strep throat, right? A lot of you have probably had this. I've had it a bunch of times, unfortunately. It's really not fun, and something that we get antibiotics for, and that you get a lot of different, medicines to help you feel better. Generally, will go away. Most will go away on their own, but some do require antibiotics. The reason that we talk about this all the time, though, is because not so much nowadays, but back in the olden days, you could get really sick from this because there was a really bad complication that could happen called rheumatic heart disease if you didn't treat this. And rheumatic heart disease basically meant that bacteria could go down into your heart and start breaking apart some of the valves that are in there. And you could have a lot of trouble later in life with this. So still now, even though that type of bacteria doesn't really exist anymore, we still tend to treat this pretty aggressively just to make sure this sort of thing doesn't happen. And so those are my 9 cases. I think hopefully like a pretty good variety of things that we would see from day to day in the emergency department. And one of the cool things is that we'll see this strep throat, which may or may not be all that serious, and go to see a heart attack, and then go to see, somebody who needs to have a chest tube and things like that. So if you like variety, if you like having to, stay mentally engaged the entire time and know a little bit about everything, emergency medicine might be something that you'd be interested in. So these are the references for all of this references, and I'm sorry that my presentation didn't work exactly as I wanted it to, but hopefully you guys got a little bit of something out of that. And I think that's basically our presentation. So I guess we can move on to the Q&A. Jide texted me. I don't know if Jide is back yet. It looks like he is. Okay, cool.
Yep, I'm
All
here.
righty. Thank you much. Okay. Why does aspirin work for heart attacks and not other medications like ibuprofen or Tylenol?
The answer to that is very, very complicated and has to do with exactly what pathway it blocks. But the answer really is that we don't entirely know, but we know it works.
All righty. Off topic a little, but how often does a concussion lead to a coma?
You want to go, Julie?
I can go. I was gonna say it depends really what you mean by coma. I feel like this is kind of a term that we don't often use really in medicine. It's more so if we're talking coma is just a period of being unconscious. You can get a coma, like being unconscious, for pretty frequently from a concussion if you get hit hard enough in the head. It's just a matter of how long does that last. Usually you're unconscious for not very long, oftentimes less than a minute. If you're talking about the people who kind of stay unconscious for a really long time afterwards, it's usually because they have some other kind of problem. So did that head get hit hard enough that now there's bleeding in the brain, and that's why they're not waking up? So kind of depends. If you're hit hard enough, it depends how you get hit. That can certainly happen.
How long does it usually take for you to diagnose a patient?
It completely depends. Some people are very obvious walking through the door. So, if like, one of my case, like somebody who was shot in the chest, that doesn't take too much too much expertise to diagnose, and I can pretty much tell you what's going on, right? Just looking down the hallway at somebody. But then there are some times where what's going on is actually really complicated, especially with older patients who have a lot of things that are going on with them. They've lived a long time and they have a lot of stuff that's wrong with them. And so a lot of different things can be going on. So things that present differently, or things that are when you have multiple things wrong with you that are all presenting together, that can take a little bit longer to figure out. And sometimes we don't figure that out in the emergency department. One of the nice things about our job is that we can admit people to the hospital and say, I'm not entirely sure what's going on, but you're not going to die in the next, 30 minutes to an hour. You're ready to go upstairs and have somebody else kind of figure some stuff out more while we kind of move along.
Right. How can you see strep throat if your tonsils are removed?
That's a great question. I can't wait to hear the answer.
So you can still see, so even if you don't have the physical like tonsillar tissue, you can still see those like white patchy spots in the tissue that's still there. The likelihood of you getting strep throat does go down once those tonsils are removed, and that's usually why people get them removed, because you're getting so many frequent infections that they try to kind of combat that with that. But if you have the infection present even without tonsils, you'll still see kind of the same kind of redness in the back of the throat with those white spots still on the tissue that's there.
All righty. Can problems with bile occur when the gallbladder is removed?
Yes. So your liver is actually the thing that makes the bile. It's your gallbladder that stores it. The gallbladder is basically just the thing that holds extra bile for when you need it, which is why we can remove it, because you're still able to make the bile even if we remove the gallbladder. So if you have something that happens to, say, your liver, or the ducts that go from your liver into your intestines to deliver that bile to allow you to digest things, then you can still have trouble. But depending on what the cause is, if you remove your gallbladder, sometimes a lot of those troubles go away, especially if your trouble is like gallstones, which primarily form in the gallbladder.
All right. Jide, is your microphone working? We'll toss one to you if it is.
Yes, it is.
There he is. All right, we'll toss this one to you. Are the symptoms of VFib and AFib similar, and how are they treated?
So they, generally speaking, they can be, but with VFib, that's going to be more concerning because that's going to be more likely to cause you to pass out as opposed to AFib. Um, And there's some aspects of the treatment that are similar and some that are different. So with AFib, or with both of them, we'll actually give you an electrolyte magnesium that can help for both of these heart rhythms. But for AFib, we can give you other certain medications just to slow down the heart rate. Um, but again, in both these conditions, we could also just do something called cardioversion, which is to shock you out of the rhythm. Um, but generally speaking, VFib is going to be much more dangerous of a rhythm.
All righty. And we'll stick with you, Jide. Can heart palpitations appear the same way as a heart attack on an EKG?
So the short answer is kind of. Um, with heart palpitations, depending on other cardiac conditions and how fast the heart rate is, there can be changes on the EKG that could look like a heart attack without actually being one. Um, versus with a heart attack itself, could be slower rates and have those elevations like we talked about. So it can depend on other conditions with the heart that can cause that.
Here, we've got a couple of questions that sort of have to do with where should you go. And the where should you go is to the emergency department or to urgent care. Looks like one of the questions already got addressed. But is an epileptic seizure something that you should go to the ER for after it happens?
Yes, definitely. Especially if it's the first time you've had a seizure, there definitely is a need for a further workup to figure out why it happened. So we look at a lot of things like blood work, sometimes imaging of the head, especially if it's all the first time. If you've had seizures in the past and this is kind of like a run-of-the-mill seizure for you, maybe you're on medications and you forgot to take it a few days, you don't always necessarily have to come and be evaluated even. You could kind of closely monitor your symptoms at home. But if you have multiple seizures back to back, or you don't really come back to your normal usual self afterwards, then it's definitely a reason to come to the ER as well.
All righty. And then another one on the same line here, would a UTI, urinary tract infection in an 82-year-old woman with mental confusion be an ER or an urgent care?
So normally anytime you're dealing with somebody who is what we call off of their baseline, which basically means they are not acting like themselves, that's almost always an ER visit. Urgent cares will generally not deal with that because even if you think it's a urinary tract infection, a lot of the times it can be something more serious along with the urinary tract infection. And so our job is to basically rule out all the bad things to make sure it's just a urinary tract infection. So most of the time that does end up coming to us.
All right. So Jide asks here, what's the best way to differentiate between two similar diseases like osteoporosis or osteoarthritis, for example? So I think this is along the lines of differential diagnosis and how you employ science to determine what's really going on.
Yeah, so for different diseases, there's a lot of different ways to tell uh, what might be one or the other. For something like osteoporosis versus osteoarthritis, with osteoporosis, they'll look at things like a DEXA scan to see basically the bone mineralization, like the density of the bone, do like vitamin D tests, um, versus with osteoarthritis you might see changes on an X-ray that suggests that it's related to arthritis. So those are kind of the different things that they might look for.
All right. Elizabeth asks, what are some of the hardest diagnoses any emergency medicine doctor had to do within a short amount of time? Have any of those situations happened to each of you in your lifetime? So what are the tough calls?
I think the really tough calls more so come down to um, knowing when it's the right time to do something. So we kind of talked to you guys about intubations, right? So when you need to place a breathing tube because someone's in such bad respiratory distress. But there's times when you're going in to do that procedure and you can't get it. And everything you're doing, it's not working. And you're trying to put this tube in, maybe you're using a video technique so you can see, and you're not seeing anything where you're supposed to see. And really, that kind of next step of what you're supposed to do after that is to physically cut the person's neck and then stick the tube in through the neck. And that's just a really hard decision to make because it's not something we do often. And you're kind of making a really lasting kind of thing to the patient where they may never be able to have that tube from their neck removed if their condition is severe enough. So it's kind of a tough call to be like, this isn't working. I have to make this choice. And then I think probably the other hardest thing that we do is when we have a patient who is brought to us in cardiac arrest. So they're not alive and they're brought to us that way. And we're doing everything we can. We're doing CPR, we're giving all the medications we can think of, doing procedures that maybe could bring these people back to life. And ultimately, after everything you've tried and enough time goes by and you're just not getting anywhere, you have to be the one to make the call that it's time to stop and we're not going to save this person. And I think that's probably actually not something we deal with infrequently, but it's kind of one of the hardest things and decisions that we have to make.
Right, I'm sure. So I'm going to make this next question a two-part question because I think a lot of people probably won't even know the base thing. First off, what's troponin? And are troponin levels still used to diagnose MI, myocardial infarction?
Yeah, so a troponin is basically a specific type of protein that is in your heart. And so we measure that protein in your blood. And when that protein is high in your blood, it tells us that something has damaged your heart. That's basically the really, really low level version of what a troponin is. We don't necessarily use it to diagnose a heart attack, but because you can have an elevated troponin for a lot of different reasons that aren't a heart attack. But if you come in the right situation with an elevated troponin, that tells me something wrong is going on with your heart. And if you're also presenting with this chest pain and you're having trouble breathing and you're short of breath and you're telling me, hey, this feels exactly like my last heart attack, then that might tell me that you're having a heart attack. So the short answer is we use it to help diagnose troponin, but it's not the only to diagnose heart attacks, but it's not the only thing that we do.
Right, and then Gabriella asked, does triage always work? Like, what if they have internal symptoms that you don't know about or the patient doesn't know about?
So that is a great question because you perfectly described the issue with triage, but it is still the sort of best system that we have to quickly determine the most obvious sick patients or not as sick patients. But you're right that some people do slip through the cracks early on, but we do still end up catching them in the emergency department. But there are definitely some flaws with the triage system.
Right. And then Madison asks, how do you take care of a patient who has had a mild stroke?
So even mild, severe, whatever kind of the spectrum is, a lot of it depends on kind of what Jide had talked about when did their symptoms start. So that determines kind of what treatments we're offering. So whether they meet that criteria to get the clot busting medicine versus not, or getting a procedure like a thrombectomy where a specialist goes in and actually takes the clot out. But again, if it's mild, then it's really a risk benefit discussion. And we talk to the patient and say, hey, these symptoms aren't really that devastating. And there's a lot of risks that go with getting that clot busting medicine. So we tell them honestly, like, maybe this might not be worth the risk of getting that medicine with how kind of minor the symptoms are. And either way, we admit all of these patients to the medical floor just for further kind of investigation, looking at risk factors for why that stroke happened and making sure we address those risk factors and to try to prevent a future kind of bigger stroke from happening.
Right. So there's a question here, how do you handle an asthma attack? And that's a multi-leveled question, but Dan, that's screaming you.
Yeah, so asthma is definitely something we see a decent amount in the emergency department, and it's actually very bread and butter, what we, something that we see a decent amount and we talk about a decent amount because people can come in, from your young, 5 or 6 year old kid who just, needs a puff of his inhaler to somebody who is actively dying because of their asthma and, needs a breathing tube and we need to do a bunch of things. So the mainstay of asthma treatment ends up being two things, which is one, nebulization treatments, which is basically things that you inhale, similar to just like a normal inhaler that help open up your airways. That's basically the trouble with asthma is that your airways are closing in on themselves and we have to open them back up. And then the other thing that everybody gets just, essentially when they walk in through the door is steroids. And the steroids also help over the long term to prevent the airways from closing again and open them back up a little bit. Once you start getting past those two things, you're a little bit sicker. You start getting into a little bit more exotic medications. You can do magnesium. That helps open up airways a little bit. You can do some intravenous medications, things into the IV. That's like epinephrine and fancy medicine called terbutaline. Those are basically the same things that you inhale, but go directly into the IV. And we use a lot of breathing assisting things like masks that help you breathe and push air in. And we also can use some sedating medicines. Ketamine is something that we end up using to help people kind of relax and breathe a little bit better. That can also help open up the airways. But ultimately, what ends up happening is if you're sick enough, sometimes we do have to actually put a breathing tube down and, actually force some of these medicines down the breathing tube and just kind of take away some of the work of breathing. But for the most part, most people turn around pretty quickly with just our basic stuff, which is a good thing.
All righty. Second to last question, and we have closed questions. Is there a more common age or age range for a stroke or heart attack, or are they in various forms present throughout the lifespan?
We definitely see it more so kind of later in life. So it's pretty unusual for young people to come in with stroke or heart attack unless they have kind of really significant risk factors. That's not to say that it doesn't ever happen. Usually that risk starts to go up, I would say like 45 and above, certainly 65 and above. And then really a lot of it has to do with that individual patient's risk factors. So a lot of things like strokes and heart attacks kind of have the same risk factors, and that includes things like high blood pressure, high cholesterol levels, and diabetes. Those are kind of the three big kind of contributors, and really it's about how well are those patients managing those problems. So if they're not taking care of themselves and not treating those conditions well, they're a lot more likely to get something like a heart attack or a stroke.
All righty. This last question is for me. It's a two-part question. So the media have portrayed life in the ER and the ED as being frenetic, somewhat insane, constantly fast-paced. Is that reality?
I would say that there's certain times of the shift where that's reality, but for example, at Christian, we do 8-hour shifts. It's not literally the entire time that we're running around like chickens with our heads cut off. Um, and plus with multiple doctors being there when something else comes in that is an emergency that someone needs to go to, we're able to kind of cover each other's backs so that one person has time to kind of take a breather while the other doctor goes over to see that new emergent patient. So while there are times where it does get very hectic and very chaotic, it isn't all the time.
All right. And the other half of the question, which I hope I will get in trouble for asking, is there any relationship between the phase of the moon and the activity that you see in the emergency department? I see Jewett
Absolutely.
shaking her head.
It's never a good time on a full moon.
Wow, that's crazy. All righty. Well, thank you all very, very much for presenting. It was a pleasure. And sorry that Jide, your laptop decided to need its own little trip to the ED, but that's the way it goes. Next week, we're going to be doing the case of the yellowing man. And I just want to emphasize to everyone, next week, we're one day later in the week. It's going to be on Thursday, not on Wednesday. I'm sure some of you will accidentally log in anyway, but we appreciate the hearts and the thumbs up and the applause. See you all next week. Thank you very much.